welcome again to our next session of our virtual VTE conference today. And again, very fortunate to have Dr. Dan Horner with us today, who is Professor of the Royal College of Emergency Medicine. He's a consultant in the Emergency and Intensive Care Medicine departments at Salford Royal NHS Foundation Trust here in the Northwest. He's a consultant intensivist and emergency physician in a large trauma centre and chairs the Thrombosis Committee at Salford there as well. Has led the service towards recognition as an exemplar centre for thrombosis care, along with several national awards. So very privileged to have him with us here this morning. He's the Regional Theme Lead for Trauma and Emergency Care Research within Greater Manchester Clinical Research Network, and has an active critical care, emergency medicine and thrombosis research portfolio, enough to keep you out of mischief as well there. So I'll hand over to you for your talk this morning. Again, thank you very much.
Okay, thanks Sylvia. That's a very kind introduction, and good morning everyone. Thanks for joining us. I'm just going to share my screen and just do the mandatory checks to make sure you can see my slides. Okay, can you see that, Sylvia? Is that okay? Okay, brilliant. So a very kind introduction from Sylvia there. I'm an emergency physician working in the northwest of England with a thrombosis research interest, and I've been asked to talk to you about diagnosis in the emergency department. My research sort of profile for the University of Manchester is just listed down there, and I do write for an open access blog, St Emlyn's blog.org. We cover lots of VTE stuff, so if you're interested in breaking evidence and current developments, that's a useful signpost. And I can be seen stalking about on Twitter every so often, drawing people's attention to new articles and research projects. So just a few details from me there. I was also had the privilege to be a topic expert for the recent NICE VTE diagnosis and management guidelines, and they were released in March 2020 after a couple of years' work, and perhaps got buried within some of the pandemic because it was just at the start of the first wave. I'm not sure they've necessarily had the attention that they should have had as a national UK guideline. So what I'm going to do today is talk a little bit about some of the complexities around VTE diagnosis, but with reference back to those guidelines so that you can see the UK position on what we should be doing and where the evidence takes us. So what's the problem for the emergency department staff and for patients with suspected VTE? Well, it's twofold really. So one is that VTE is a serious diagnosis with lots of incumbent problems, as I'm sure I don't need to tell anyone who's already dialing in. 30-day case mortality rate for an acute diagnosis of VTE is still around 10% within the first 3 months. So really serious complications of the disease. And between 30 to 50% of patients diagnosed with acute VTE will suffer long-term complications, and the risks of that are made worse by any delays in diagnosis, especially with regard to deep vein thrombosis. So a really serious diagnosis, and important that we get it right, and important that we start treatment as soon as possible. But we see lots of patients coming through the emergency department with swollen legs, with shortness of breath, with chest pain, with syncope. And whilst we could look to exclude VTE in all of those patients, that would mean that we perform very large amounts of scans, that we do lots of invasive investigations, that we use lots of anticoagulation when we don't necessarily need to, and we will perhaps cause harm with that type of approach. When you look at the diagnosis rates for VTE in the emergency department cohort, around 1 in 5 patients that we investigate for DVT with ultrasound will turn out to have a DVT, so 4 out of every 5 won't. And in terms of PEs, it's even lower than that. So only around 1 in 20 patients that we send for CTPA will have a positive diagnosis. And of course, once you've done a CT imaging study of the lungs, then you put that patient at risk of radiation, of incidental findings that will lead to further investigations, and there are complications. So it is a balancing act about how aggressively we investigate this disease, and we need to be sensible and try and practice sensible medicine. And how do we do that? Well, it's a three-stage process, I would suggest. So the first thing to do when we're seeing any patient and VTE or an acute diagnosis of VTE is on our radar, is we need to think about a clinical assessment and an estimation of pretest probability. So what I mean by that is a thorough history and a clinical examination to elucidate the potential diagnosis of VTE, but then to think about the risk factors that might make a diagnosis of VTE more likely. And there's been lots of work over the last 20 years looking at how we organize those historical and examination factors into a clinical decision rule or a pretest probability so that we can make sure it's individualized and it's reproducible. So it doesn't matter about the clinician's inherent bias or their level of experience, but we can use that rule for everyone and use objective criteria to give us an estimation of VTE risk. And that's important because the risk of someone having a VTE guides your investigations then. And I'm sure lots of you will be familiar with the process of identifying lower risk patients at VTE and using blood tests then to try and exclude the disease, such as a D-dimer. And we'll talk about the different ways in which we use the D-dimer over the course of the next half hour. But there are other blood tests as well that can help with the diagnosis of VTE, so raised inflammatory markers, that perhaps might suggest an alternative diagnosis, other measures of coagulopathy, different type of tests. So we use blood tests in a variety of different ways when we're thinking about acute VTE diagnosis. And then following blood tests, we're looking at imaging studies to try and confirm or refute the diagnosis. And although we have definitive imaging tests, such as a vascular sonography to look at deep vein thrombosis, or a CT pulmonary angiogram to look for evidence of pulmonary embolism, we also have lots of other additional ancillary radiological tests that can help guide the diagnosis and guide the measure of investigation, such as point of care ultrasound, focused echocardiography, and perhaps physician-guided ultrasound investigations and subtle chest X-ray signs of other bits and bobs. So, if you take nothing away from this talk other than one slide, I would urge you to think about all VTE diagnosis in the emergency department like this. We do a clinical examination and a history, and we think about pretest probability and what the risk of VTE is for this individual. We think about ancillary blood tests then that might help change that probability estimate and can sometimes refute disease or make it more likely. And then we think about definitive imaging investigations and whether we need to take those forwards, and if we do, which ones do we need? So if we move on to different types of VTE then, we'll start with deep vein thrombosis. And I suppose the first point to make about deep vein thrombosis is that none of us have X-ray spectacles. So there is no clinician in the world that can look at a swollen leg and tell you with confidence whether that patient has a DVT or not. We can estimate likelihoods and we can think about probability, but we just can't tell for sure. And we've studied that and we know it's a fact. This is a reference to a Lancet paper in 1984, where they took consultants from different specialties, vascular, surgery, emergency medicine, acute medicine, other specialties, and they asked them to look at patients with swollen legs and suspected DVT and put their money where their mouth was, in essence, to kind of, make a commitment to whether they felt they had DVT or not. And their best guess was roughly the same as flipping a coin when they looked at it in statistical modeling. So when we looked at kappa scores, you could see that there was very little reliability between the consultant decision-making and the final diagnosis. And we've learned this lesson over time, and we now rely very heavily on objective testing because there are lots of DVT mimics. So cellulitis, lymphadenopathy, and lymphedema, different types of trauma that might present atypically. Lots of mimics for DVT, so we really can't be sure about the diagnosis. So we have to rely on objective testing, and the first point of objective testing really is an estimate of pretest probability. And you can do that through a STOLT assessment, so you can just use your own history and examination and your own inherent clinical skill to try and decide whether you think someone is high, moderate or low risk. But again, that will differ between clinicians, it will differ with experience, it will differ based on your recent encounters. So anyone who has perhaps seen someone within the last few weeks that's been diagnosed with a DVT that presented atypically will have a very low threshold for thinking about the diagnosis, whereas someone who's fresh out of medical school and has never seen a DVT before may be very objective and a bit more scientific and think that it's unlikely in most patients they see. And clinical decision rules or clinical prediction scores allow some objectivity around that. You know, they take the most focal aspects of the history and examination and they put them together to try and provide an objective measure of the likelihood of deep vein thrombosis. And many of you will be familiar with the Wells score, but I put this slide up, I suppose, just to highlight that that's not the only score in existence. You know, there's a Hamilton score, a Kahn score, an Udega score, there's an Andre score, numerous. And this systematic review found at least 8 that refer to different populations subtly, and each score has slightly different components, but they all aim to do the same job, which is an objective estimate of pretest probability, so you know whether someone is lower risk or higher risk for deep vein thrombosis. NICE has looked at the evidence for all of these scores, and the take-home message is that they believe the Wells score to be best validated, and they think that the 2-level model is the most simple and reproducible. So the original Wells score looked at a low and intermediate and a high risk category, and that's been simplified to a 2-level high or low category now, and that's available online at the URL below. What do we do after an estimate of pretest probability? So we think about blood tests then. And the natural blood test that follows on from an estimate of pretest clinical probability is a D-dimer. Now, it's important to highlight, I suppose, that the real role of the D-dimer is for low clinical pretest probability patients. So the D-dimer is a sensitive tool, meaning that it will be raised in the vast majority of patients who do have a DVT, but its specificity is very poor, meaning it will often be positive for another reason that's not DVT. So if we perform this test in a high-risk group and we use it to guide decision-making, it's not really going to be very helpful, because even if it's towards the lower end of the spectrum, we still have a high clinical suspicion and we're still going to want to progress to definitive investigation. However, if we have a low clinical pretest probability estimate and our D-dimer is low, then those 2 tests have been shown together to safely reduce the possibility of deep vein thrombosis to a really, really low levels that mean we effectively exclude it. And the original Wells paper looking at this is referenced there below from the New England Journal of Medicine in 2003. Now, it's important to point out there, I suppose, 2 things. So one is that the D-dimer as a test is not a positive or a negative test as such. It's a continuous variable, which means it goes from 1 up to 10,000, 20,000, 30,000. And where we decide the cut point is based on evidence and our research work looking at the incidence of VTE if we accept threshold at a certain level. And many of you will be familiar with the threshold published in the literature of 500 micrograms per litre. But of course, that depends a little on your assay and the type that you use, and different areas use different assays. We'll come on to that in a bit. But that 500 cut point is one that's defined by evidence. And again, it's not a positive or negative test. People often think about D-dimers as green or red, and that's not quite accurate. It's just a number, and where you decide to put the threshold is up to you to a degree. On that topic, there have been a number of papers recently and a number of research objectives trying to make better use of the D-dimer than we do already. And in order to improve the specificity of the test, lots of authors have looked at raising the threshold for D-dimer above the norm or above the conventional threshold, which is often set quite low. This is a reference below from Schutten et al. Looking at a paper in the BMJ, a systematic review of the concept of age adjusting the D-dimer. So this is where you take the age of your patient, if they're over 50 years, and you times the D-dimer, times the age by 10, sorry. So a 70-year-old patient, instead of having a threshold, a D-dimer of 500, would then have a threshold D-dimer of 700. And of course, that increases the amount of patients in which you can potentially exclude deep vein thrombosis. And the evidence would suggest that you don't compromise your sensitivity. But we need to have some cautions around the use of age-adjusted D-dimer, because as I mentioned before, different people have different assays, different hospitals use different cut points, and it's really important not to simplify this because it is quite a complex intervention. So this is a screenshot from MD Calc with the web address listed at the bottom that tells you how to age adjust your D-dimer dependent on your assay, the units you report in, and your conventional threshold. So at Salford, where I'm based, for instance, we report D-dimers in D-dimer units, and our typical cut point is 230. So our age-adjusted threshold becomes 5 times the age. So what's 5 times 75? I need to think about that. It's about 375, isn't it? There we go. So in a patient I was seeing who was 75 years old, who had a low Wells score, a low clinical pretest probability, and a D-dimer of 350, which would be above my conventional cut point, it would be below my age-adjusted cut point of 375. But that would be different if my conventional cut point was 500. So important that you acknowledge what assay you use at your site, and that you make sure if you introduce measures like this that they're done robustly and that they're supported by evidence. In addition, other authors have tried to adjust the D-dimer based on the clinical pretest probability. So you can adjust the D-dimer threshold based on whether someone is low risk Wells score, intermediate risk Wells score, or high risk Wells score. And these authors have suggested something even simpler, which is where they strip the Wells score down to only 2 clinical characteristics, one of which is DVT the most likely diagnosis, and the second of which is the leg swollen at all. And if you don't have any of those criteria, then they record you as having 0 items on their score, and that's a particularly low pretest probability. And they've looked at just introducing a threshold of less than 1,000 nanograms per mil for D-dimer. So rather than the conventional cut point of 500, they've escalated that to 1,000 and said, if you're particularly low risk, can we increase the threshold even further? What these authors have found is that the prevalence of DVT, if you exclude patients based on those numbers, is very, very low indeed. So it's 0.3% here, which is an acceptable miss rate, and is in keeping with the miss rate performed in the original Wells and conventional cut point D-dimer studies. Now, this has not been prospectively validated, this work, so I'd urge caution around interpretation, but I just wanted to show you what people are thinking in terms of how they adjust the D-dimer related to clinical probability and the effect that can have on clinical diagnosis. This is what we said in NICE in 2020. So there was evidence to support the use of age-adjusted D-dimer thresholds on systematic review, and that was fairly convincing. So NICE added in a recommendation on that. And that applies to both point-of-care quantitative tests and to lab-based quantitative tests. And it applies to both deep vein thrombosis and pulmonary embolism. So highlighted there, and if you use an age-adjusted threshold, then you can be confident that NICE has support and guidance that is robust and will allow you to defend that practice. What happens if your D-dimer is raised above your chosen threshold, or your clinical pretest probability score is particularly high? Well, then we're into more definitive imaging, aren't we? And NICE guidance hasn't really changed here, in that it just suggests that patients have an ultrasound scan of their leg to exclude the diagnosis definitively. Worthwhile highlighting, I suppose, that NICE still talks about proximal leg vein ultrasound, and we'll come on to that in a second. And if you can get a result within 4 hours, so if you can get a same-day ultrasound, then there's no need for any kind of anticoagulation therapy at all, and you can just wait to see what the scan shows. But if that scan is going to be delayed, then it's important to think about using interim therapeutic anticoagulation to treat that patient as though they may have a DVT while you wait for the definitive test. And most of us would probably be using a DOAC for that now. I'd be interested to hear any questions and comments on that, because we used to give all of these people subcutaneous low molecular weight heparin pending definitive diagnosis. But recent evidence suggests that it's equally safe to use Apixaban or Rivaroxaban in these patients. And NICE guidance would now support that as used for an interim anticoagulant therapy, as would the BTS guidelines on outpatient management for PE and multiple other guidelines. Just as a quick point of interest on ultrasound scanning, although NICE recommends proximal leg vein only ultrasound, so this is the popliteal fossa and above, looking for proximal deep vein thrombosis, actually many sites are moving towards whole leg ultrasound to make sure they look at the calf veins, and they identify any other differential diagnoses that might be causing symptoms, and they allow themselves a bit more leeway around risk-benefit balance when they're thinking about diagnostic options and treatment options. And this is just a snapshot from the recent Getting It Right First Time report. Now, the national report for this is not been published, but individual sites have received their data. And I suppose I just wanted to highlight that when this project has asked 144 NHS trusts and has received responses from, I think, over 100 of those, so a very good response rate about what they do in terms of DVT diagnosis. You'll see that over almost 2/3 of sites are using whole leg scans for DVT diagnosis. So that's interesting, I'm happy to discuss it, but I suspect most sites are using that for a variety of reasons, one of which is a bit more convenient for patients because it can cut down the number of patients that need to return for a follow-up scan. And also there is pretty good evidence that if you identify isolated distal deep vein thrombosis in the calf veins, then anticoagulant therapy can help reduce the rate of recurrence, propagation, and pulmonary embolism. So this is a Cochrane review reference at the bottom from 2020, published fairly recently, which is pretty unequivocal about the evidence base for treatment of isolated distal DVT. Happy to discuss that in the questions if needs be, but I thought it would be of interest for you to know that. So if we stop DVT for a minute and we move on to pulmonary embolism, this is even harder, really, because patients present with a myriad of symptoms to the emergency department when it comes to PE. So we don't just have swollen legs now, we're talking about chest pain, palpitations, shortness of breath, syncope, pre-syncope. People can present in a really broad variety of ways. And in addition, the tests are a bit more invasive for PE. So CTPA comes with a radiation dose to the thoracic cavity. In addition, it's more likely to pick up incidental findings that might cause ongoing need for investigation. It's a dose of contrast, and so some people would raise concerns about contrast-induced nephropathy and other side effects, excuse me. But the stakes are a little bit higher because pulmonary embolism is a more serious diagnosis than deep vein thrombosis in many ways because of its proximity to the heart. And so it's hugely important that we get this right, but we don't over-investigate people where possible. We take a very similar approach to the diagnosis of pulmonary embolism as we do to deep vein thrombosis, in that we think about clinical pretest probability, we think about ancillary blood tests and how we use those to complement the diagnostics, and then we look at invasive investigations. We do have slightly more evidence in this terrain, which I'll run through quickly now. And the first slight change is that we don't have X-ray spectacles for PE, but we do have the Perk Rule, which is a helpful clinical pretest probability set of criteria, which if you have none of these criteria at all, it reduces the likelihood of pulmonary embolism to less than 1.8%. And most authors would suggest that the benefits of investigation are almost equivocal to the risks at a diagnosis rate of around 1.5%, because you probably cause just as many complications as you do make the diagnosis. So the Perk Rule has been studied in a variety of settings. This is one report from JAMA, which looked at a cluster randomized controlled trial, randomizing emergency departments to use of the Perk Rule versus their usual standard of care. And what you see here is equivalent rates of VTE, so no extra missed cases really, but you significantly reduce the number of CTPAs performed and you shorten your time in the emergency department a little bit, which we always like, although both of these groups are over 4 hours, as you'll notice. But in terms of reducing investigations and the harm that can be done through investigations, the Perk has a potential role here. And as such, NICE has gone on to recommend considering use of Perk. And some people still have strong feelings about this, and it's really important to highlight that Perk is only ever to be used in a group of patients where you have a low clinical pretest probability estimate. So these are people who you really think PE is unlikely in. And that's quite hard to quantify. In the proper study that I just presented, they talked about the clinician estimate of PE being less than 15%, but I think that's very subjective, it's very variable. So some centres have introduced different methods of scoring before application of the Perk tool. For me, I use it in patients whom I think PE is really quite unlikely, but I'd like to provide some assurance to myself that I have thought about it and acknowledge the potential risk. And for those patients who are Perk negative, I'm happy to exclude PE with no further investigation. If we move on from Perk Rule then to more formal clinical pretest probability assessment, now there are a variety of ways of doing this for PE as well, and there's a Geneva score, a Wells score, different types of Wells scoring, and some authors have compared this to just pretest probability, again, your best guess estimate as to whether someone's low, intermediate or high risk. And there's no great disparity in how they perform. So again, most scoring systems are fairly equivocal in terms of how they apportion percentages for likelihood of thrombosis. But there's the original Wells reference here, looking at the 3-tiered Wells score of low, moderate, and high risk, putting percentage of PE diagnosis of somewhere around 5%, somewhere around 10%, somewhere around 30%. And then the Christopher study investigators took the Wells score and slightly simplified it into just a 2-tier dichotomous model in 2006, published a large study suggesting that an algorithm involving this with conventional D-dimer cut points was sufficiently valid to exclude pulmonary embolism in the low risk and negative D-dimer patients, just using a PE unlikely model. So as a result of this, NICE has gone on to recommend a 2-level Wells score in this group as well. And that's a PE unlikely or a PE unlikely only. But it's important to remember, for reasons I'll come on to shortly, that the original Wells score was a 3-tier score and that other scores are available, and that this is just really a clinical estimate of the likelihood of probability that then informs your further testing. What other tests are we going to do? So we're into blood tests again, aren't we now? And we can again use a D-dimer test with a conventional cut point. And if someone is a low pretest probability or PE unlikely, and they have a negative D-dimer by conventional cut point, then all of us would be happy to say that a PE has been excluded in that patient and there's no need for further imaging. Now, if we take that forwards to look at how best we can use the D-dimer in PE, there's a bit more work done on this. So Regini et al. Looked at the initial concept of age-adjusted D-dimers in the use of PE and published some data in the Adjust PE study in 2014, highlighting that you can raise the threshold for people over the age of 50, still keep the sensitivity of that diagnostic algorithm, but improve your specificity and reduced imaging rate. So that was a positive step forwards. Van der Heulen, a group from the Netherlands, have taken that slightly further to look at something called the years score, where they create a slightly different clinical probability estimate rule, looking at different tiered categories, and they introduce graduated measures of D-dimer, so that if you are low clinical pretest probability by a year's decision rule, your D-dimer threshold could be raised to 1,000 rather than 500. And if you're intermediate, they have a threshold of 500. If you're high risk, again, most patients would go straight for CTPA or definitive imaging there. And that's an interesting concept that they suggest is safe in practice. And then most recently, we've seen from a group in Canada, led by Clive Kieran, the idea of a graduated D-dimer based on the original Wells score. So this is the concept that if you are low risk by the original Wells score, you can raise your threshold to 1,000. If you're intermediate risk by the Wells score, you could keep your threshold at 500. And if you're high risk by the Wells score, then you need to pursue further imaging. And again, that group would suggest that you can reduce your imaging rates and exclude PE in more patients if you flex the way you use the D-dimer. This is a comparison table from the Kieran study, the PEG-ED study, that looked at how the PEG-ED strategy performs compared to age-adjusted D-dimer compared to the year strategy. And you can see here that what happens in terms of chest imaging is that the PEG-ED strategy significantly reduces it compared to both an age-adjusted strategy and the strategy and the conventional strategy in low-risk patients and in moderate pretest probability patients. And there are no difference really between these groups in terms of missed VTE and downstream sequelae. So this is interesting data. It wasn't really quite in time for NICE guidelines, the idea of graduated adjustment strategies. So at the moment, NICE guidance only really recommends age-adjusted D-dimer testing if you want to flex the way you use the D-dimer. But I suspect surveillance will flag up use of clinical pretest probability scoring adjusted D-dimer thresholds in the next iteration. And it'll be interesting to see what they say there. Now, there are supplemental tests for diagnosis of pulmonary embolism. So some people will talk about focused point of care ultrasound. And of course, there is some evidence suggesting emergency physicians can identify proximal VTE through point of care ultrasound. And it's something that is increasingly being seen in practice to try and give us early ideas about who might have an acute diagnosis. There's also focused echocardiography, looking for any signs of RV strain or dilatation. And these are just a few examples of the things that can point you in a direction of pulmonary embolism with RV strain at the bedside. And this is a very useful and easily applicable diagnostic tool without any radiation. But of course, it's not a definitive test and it will never give you a yes/no answer. If we're heading towards imaging, then NICE still recommends a CTPA as first line, really. And it does talk about VQ SPECT imaging for those who have a particular contraindication. But most patients who you think will require definitive imaging will need a CTPA. What do we do for outpatients? So there's been a lot of evidence on this recently, and the British Thoracic Society guidelines have published fairly comprehensive recommendations about who can go home while they're waiting for their tests to exclude DVT and pulmonary embolism. We've been comfortable doing this in the UK for deep vein thrombosis for a good decade or so, but for PE, it's only recently crept into practice. And it's nice to see some of the evidence to support the safety of this practice really developing over the last 5 years. What I think is important is to try and make sure that if you are thinking about outpatient management of these patients, that you identify they are low risk for complications. And there's a variety of scores that can help you do that, such as the Hestia score, the SPESI score, and others. And all of those will allow you to objectively get some idea of risk and then discuss that with the patient in front of you. And NICE is fairly clear now that this is a safe practice when you apply it to low-risk patients, but it does need to mirror the evidence base of how you deliver outpatient management. So by that I mean, how are you going to ensure adequacy of follow-up? How are you going to talk about long-term treatment if a PE is diagnosed? And what kind of safety net does your patient have if they have any complications of thromboembolic disease or of bleeding, which are the two big challenges. I realise I'm running short on time, so to motor through the last couple of slides, the last things I would say, I suppose, is that there are lots of other potential VTE diagnoses to make in the emergency department. So we could talk about cerebral venous sinus thrombosis. We could talk about PE in pregnancy, which are a particularly challenging cohort to diagnose. We could talk about unusual site thrombosis like mesenteric vein thrombosis, portal vein thrombosis, and others. You know, there are other lectures, I'm afraid, and a half hour is a real kind of short-term window to talk about the diagnostics. But what I would kind of point you back to is the same threefold principle that I talked about at the start. For all of these complex diagnoses, what we're really doing is trying to build an estimate of pretest probability. Do we think this patient is low risk or high risk for cerebral venous sinus thrombosis, for example, if a patient presents with a headache? And we need to think about the historical factors that will guide that decision, such as use of the contraceptive pill, malignancy, previous history of thrombosis. And we need to think about whether there are any clinical decision rules that might help guide us on that. And then we need to think about whether blood tests would be useful in adjusting our probability threshold. And there is published evidence on the use of D-dimer in the diagnosis of CVST, as there is for other diagnoses and unusual site thrombi. And then we need to take that information forwards to guide us about imaging decisions. So all of those complex diagnoses, I'd urge you to go back to basics and think about this as a three-step process. I shall stop there so that we've got some time for discussion, but thank you for your attention and thank you for dialing in to the Thrombosis Week, and I look forward to any questions you have. Thank you.
Right, well, I hope you're ready for this because there's loads of questions here now.
Yeah.
The very first one I'm not going to ask because you have spoken about it, and if the person that asked the question wants any further comment, if you just message me back again, because it was about age-adjusted D-dimer, so we won't go into that one. So Abdul Hamad Hamdi Ramdan, bless you, he's got about 1 million questions here for you. So first off,
should we do quick fire?
Quick fire, yeah, absolutely.
I shall do my best.
In IV line related DVT, do you remove the line like CVP or dialysis catheter immediately or after bridging with anticoagulation? And for how long would you treat?
Okay, that's an excellent question. So I presume we're talking there about catheter-related thrombosis, usually due to the presence of an indwelling proximal venous central line. So you do see sort of peripheral thrombophlebitis around small cannulas, which I think most of us would not treat unless there was significant extension. But if the line is proximal and indwelling, our current practice is to anticoagulate prior to line removal. So we would tend to use a treatment dose of low molecular heparin for at least 3 days before we remove the line. Sometimes we don't remove the line if it's flushable and if it's still working and there are no signs of infection or clinical symptoms and it's an incidental finding on sonography, we might leave the line in. But if we did want to take the line out, we'd wait until we'd had at least 3 days of anticoagulation before we took it out. And then we would treat that as a line-associated thrombosis with at least 6 weeks anticoagulation.
Brilliant, thank you. And next, if clinically DVT but ultrasound is negative, what do you do in this situation?
Yeah, another good question. So is this clinically DVT? I would kind of point you back to some of the slides at the start that I think we don't know what a clinical DVT is. We often strongly suspect a DVT, but we find no evidence on vascular sonography. And that doesn't necessarily mean we're right and it is a DVT. But I agree there needs to be a bit of caution around some of these cases. I think NICE guidance does offer very clear rules about when to repeat the ultrasound. So it would suggest that if your Wells score is high risk and your D-dimer is raised, but there's no evidence of DVT on sonography, then in those patients, it's worth repeating the ultrasound after a week's time. And I'd highlight there that there's no role for anticoagulation in that interim week. So if you've not seen a DVT on the initial ultrasound, we would never treat with anticoagulation pending a repeat ultrasound. And the reason for that is that the principle of the second ultrasound is I want to make sure that we haven't missed a small DVT that's now going to propagate and reveal itself at the second ultrasound. The only way to do that is, of course, not to treat and allow that to happen. If you treat in the interim between the first and second ultrasound, you're likely to stop any form of propagation, have a second negative ultrasound, and then say there was never a DVT there in the first place, and that would be the wrong conclusion to make. So NICE guidelines does touch on this, both in the recommendations and in the evidence statements, and I'd suggest you go back and have a look at those.
Brilliant. He's also wondering, in superficial vein VTE, do you give treatment?
Yeah, so another good question. I think there is some evidence from RCTs that treatment reduces the rate of pulmonary embolism and propagation in superficial venous thrombosis that have extended or are greater than 5 centimeters in length or involve specific areas of the proximal leg. So we have great vascular sonographers locally, and they give us a very good description of the superficial venous thrombosis, and we use that guidance to make treatment decisions. So if it's more than 5 centimeters in length, if it's anywhere near the top of the femoral vein, if it's propagating despite simple measures, then we would use all of those as an indication to treat more formally with anticoagulation, yes. But I'd highlight that the evidence suggests a prophylactic dose of anticoagulation for treatment of SVT, not a treatment dose, and that's a fairly common mistake to make.
Okay. And again, just wondering whether you see any cases of VTE related to oral contraceptive pill.
Yeah, that's a reasonable level risk factor for VTE, and it's something that we should always be asking about. It does feature in various clinical pretest probability scores, and in patients with a headache, it's something that should make you sit up and take notice and start thinking about the possibility of cerebral venous sinus thrombosis. Okay.
And now we've got a thrombosis nurse from Oxford. Thank you very much for your talk. Can I ask about positive distal leg thrombosis? Current practice is to ask patients about a choice of weekly serial scanning, and if progression of thrombosis is noted, then that's the time to decide on treatment dose of apixaban for 3 months. Just wondered what your best practice was.
Yeah, so a very good question, and that sounds like a sensible way of doing things. We're a bit more aggressive, and we tend to treat them directly. And this was my MD, and it's my particular area of interest. So I don't want to hijack the time by waffling about it. But my original research project was to randomize patients with a diagnosis of distal deep vein thrombosis to anticoagulation or serial sonographic follow-up. And it was just a feasibility trial, but we found a reasonably high rate of propagation and PE in the serially managed group, especially in those who had unprovoked thrombosis or other ongoing risk factors. And my research has been put together with other trials in the Cochrane review, which suggests that overall the benefits of anticoagulation outweigh the risks. So our approach locally is to offer anticoagulation for a diagnosis of distal deep vein thrombosis, and to suggest that will be 3 months as per usual, followed by a clinical review. If the patients are particularly concerned about the idea of anticoagulation, or they have a high bleeding risk, then an alternative strategy we use is serial sonographic follow-up. But we're perhaps more at the slightly more aggressive spectrum than you guys are at Oxford of treating these.
Okay, so Joseph is asking, with VITT, if thrombosis and thrombocytopenia positive at the same time, would you anticoagulate?
Yeah, so VIT is a very specific diagnosis that's very rarely confirmed in the emergency department. And just for everyone else who's on the chat, you know, VIT is vaccine-induced thrombocytes, vaccine-induced immune thrombocytopenia and thrombosis. It's an unusual, very, very rare reaction that we are seeing as a result of widespread vaccination programs. Patients tend to present with systemic thrombosis at unusual sites, so that can be CVST or portal vein thrombosis or clots everywhere. You know, we've seen a couple of really tragic cases of extensive disseminated thrombosis. And they're also thrombocytopenic, as Joseph rightly points out. Now, there are a couple of challenges with VIT patients. So the first one is that it is hard to confirm the diagnosis acutely because these patients need to have assays sent to look at whether they have antibodies to platelet factor 4. That's rarely done in-house acutely. It often takes a day or so to get, unless you're in a hemostasis center of excellence. So you don't really know what the diagnosis formally is for a day or so. Yes, I would suggest, Joseph, that these patients do need anticoagulating because the thrombosis is usually so extensive you can't not treat. The important thing to think about is to try and use an alternative agent to heparin. So VIT has many parallels with heparin-induced thrombosis and thrombocytopenia, and as such, the national recommendations and the ISTH recommendations are to not use heparin-based anticoagulants. So most of us would use intravenous argatroban, a factor, or we'd use a DOAC, or we'd use fondaparinux, you know, a different type of anticoagulant. We would usually treat with anticoagulation if there was confirmed thrombosis, and we would watch the platelets very carefully. And in terms of thrombocytopenia, the recommendations are not to give platelets as a transfusion because that can potentially worsen the immune reaction, but actually to use immunomodulatory therapies, which would include steroids, immunoglobulin, and you can think about plasmapheresis in these patients as well. But these are really, really complex patients. VIT is, again, another lecture on its own. I think Beverly has already covered it several times during the thrombosis week. So if you want to know more about VIT and the complexities, I suggest having a look at those lectures, but also having a look at the British Society of Haematology website. They have an expert panel that's published recommendations and guidance on how to manage VIT. There's a guidance document from the Royal College of Emergency Medicine, and there's a guidance document from the International Society of Thrombosis and Hemostasis, and they're all really good resources.
Okay, last question. Dilemmas of D-dimer during COVID.
Yeah.
Your opinion?
So I don't really think this is a dilemma for me. In COVID patients who require hospitalization, roughly 80% or more will have a raised D-dimer, and often that comes just from alveolar damage and D-dimer release and fibrin breakdown within the alveoli itself. It's not to do with clotting. So once you know that in your population 80% of patients are going to have a positive D-dimer, I don't think it has much of a role in exclusion of disease, really. So we don't tend to look for it. We don't tend to use it to discriminate on diagnostics in the emergency department because we assume it will be raised in everyone, and we rely more heavily on clinical triggers such as a step change in oxygenation, hypotension, cardiovascular compromise, or worsening symptoms to guide decision making on CTPA imaging.
Okay, I actually lied. This is the last question. So this is from Sue Bacon. Would you advise the use of anti-embolic socks to treat symptoms of DVT, as often the swelling is? Vascular surgeons would advocate that. Just wondered.
Yeah, it's a good question, this one. So we did have some stockings that we used to give out, but we found patients didn't really like them. They were fairly non-compliant with them. You know, they do help a certain proportion of patients, I think, but the evidence is pretty equivocal. And there's actually a study that's recruiting at the moment in the UK called the CHAPTER study, I think, which is looking at the use of embolic stockings post-DVT diagnosis and randomizing patients to get them reliably versus standard care. I think if you've got equipoise and you're not certain, Sue, then I'd advise you to get in touch with the chief investigator for the CHAP study and see if your centre can start enrolling patients, because whenever we're not sure what the answer is, well, undoubtedly the best option is to offer patients the opportunity to participate in randomised controlled trials where they can access those treatments, and they can also help us get a definitive answer about what works and what doesn't work.
Thank you both. That was another brilliant session. So thank you both so very much.